My name is Dr. Swati Patel. I'm a gastroenterologist at the University of Colorado Medical Center. And I'll be hosting today's podcast where we will learn about the most recent results published from the Cancer Prevention Program, or CAP, about the effect of aspirin in cancer prevention for Lynch Syndrome patients. I have the distinct honor of introducing our expert guest today. Sir John Byrne is a medical doctor and professor of clinical genetics at the Translational and Clinical Research Institute at Newcastle University, the chair of Newcastle Hospitals, and the chief investigator of the CAP study group. We also have co-author Dr. Tony Seppälä, an adjunct professor of colorectal surgery in the Department of Gastrointestinal Surgery at Helsinki University Hospital. We are delighted to have these world-renowned experts in Lynch syndrome and chemo prevention. Professor Byrne and Dr. Seppälä, thank you so much for being with us today.
It's a pleasure to be here.
Thank you for the invitation.
So let's dive right in. Professor Byrne, can you set the stage a little bit and tell us the background of the CAP2 study? Why did you envision performing it, and what was the rationale for the design?
Thanks, Swati. Well, this story begins more than 30 years ago in a house near Newcastle where I was looking at a little boy with FAP. His mother had had a surgery. She had osteomas on her forehead, and so did he, but his endoscopy was clear. And it struck me that he was going to get polyps with his FAP, and why wouldn't we do something to try and prevent that? And just at that point, we'd realized that the APC gene was pivotal in general colon cancer as well as in FAP. And so the idea sprung in my mind that maybe we could do genetically targeted trials, because if we could slow the disease down in people like that little boy, then maybe that would be relevant to the general population. So we set up a study which became CAP1 across Europe and recruited a couple of hundred children, teenagers with FAP. But then just as we launched that, we were involved in the discovery of the mismatch repair genes with Kolodner's group. And of course, the Lynch patients were an obvious second group and a far better target. Although they didn't represent all of colon cancer, they certainly represent the 1 in 6 people with MSI high cancers. And they're a big group in themselves. We now realize an incredibly big group with maybe 4 per 1,000 people affected. So then the question was, how do we intervene? So we'd already decided in FAP to go with 2 interventions, resistant starch or fermentable fiber as one of them. And we have data coming out on that in a few weeks, months' time, which we can have another podcast on. But then also aspirin, because in 1988, Gabriel Kuhn in Melbourne had published a seminal study, case control study, where he found that basically people who took aspirin had less bowel cancer, was the observation, and aspirin-like drugs, NSAIDs. And that spawned 100 publications in the same sphere of cohort studies, epidemiological studies. But before all those came out, I'd realized this was the perfect drug to test. It was over the counter, it was cheap, and we could try it out, first in our FAP patients, but then obviously in our Lynch patients. And because we were using this as a pharmacological treatment, we used as high a dose as we dared to use, which was 2 tablets a day, or 600 milligrams. Has to be remembered that the cardiovascular trials began with 1,200 milligrams back in the early 80s, and then worked their way down, and we'll come back to that later. So we basically looked for 1,000 people. I thought it would be easy. I mean, I never realized how hard this was going to be. So we didn't get the funding and got started. Our first patient was in 1999, which was 5 years after we started the build. And we managed to get our 1,000 patients in 16 countries in 43 centers. We were shipping starch and aspirin all over the world. We never quite got South America because our starch was impounded in the customs. They thought it was drugs, these little packets of white powder. It was a fascinating experience. And we managed to get our 1,000 recruits. We planned a 10-year follow-up. So we, first of all, looked, in the New England paper in 2008, looked at the very first results as we finished intervention. We averaged 2.5 years of treatment for the group. And initially we were very disappointed. There was no impact on adenomas. In fact, nothing worked. But we managed to keep on going. And when we looked at the cancer rates as the years began to go by, we could see that the cancers were different. So we looked again for the second time in 2010-11 and published in The Lancet. And then we came back with our 10-year data in 2019-2020. And before I tell you about that, I'll hand over to Tony, because one of the big boosts was a meeting last year. We'd realized we could maybe expand our data beyond the 10 years we had consented using registry data. And Tony will tell you that part of the story.
So yes, the actual follow-up was a mean of 10 years, but as many of you know, especially England, Wales, and Finland have a very nice access to registry-based data, which we thought we could make use of. And we decided to extend that follow-up based on this registry approach using that data. And we were able to collect as much as 8,500 follow-up years by that approach.
So what we basically found was that effectively gave us up to 20 years data for the very longest member of the group. And Audrey is still with us and still a diligent follower of CAP. And what we found remarkably was that the effect we'd seen in 2011 was amplified. And there was if you look at the graphs in the paper, basically the cumulative incidence just shows that the two lines are heading off in two separate directions. And the effect seems to persist certainly into 15 or 16 years. Beyond that, the numbers get quite small. And the absolute numbers are really quite dramatic. So in terms of colorectal cancers, we had 861 people, 50-50 between the two groups. And if you look at the intention to treat, which is what the trialists get hooked up on, then the HR was 6.65. So we had about a third less. But in terms of efficacy, I mean, that was statistically significant, and that's important. So the primary endpoint was significant. But the most useful clinical data is to look at two different things. First of all, look at the per protocol group, the people who actually took the aspirin for 2 years. And secondly, not to restrict ourselves to a hazard ratio which stops at the first cancer. In Lynch syndrome, of course, you can get multiple primaries. So we used a negative binomial analysis, which is called incidence rate ratio, and that allows you to count all of the cancers, not just the first one. And if you look at the incidence rate ratio in the people who took the aspirin, there were 50% fewer cancers in that time period. And what's remarkable is that, remember, we treated people for an average of 2.5 years. So this effect is still being seen more than a decade after we stopped the aspirin. And indeed, the first effects weren't seen for about 4 years, which of course is reflected in all of the literature. This seems to be a very delayed effect. And just to give you an absolute number, of the 427 people who took the aspirin compared to the 434 who were on the placebo tablets, there were 29 fewer colon cancers in that group. So that works out at about 1 cancer prevented for every 24 or 25 people treated, which compared to most of the interventions that we explore is dramatic. A really powerful and very cheap effect. So we're very excited by that.
A fairly remarkable finding. You've been talking about the effect on colorectal cancer. Can you expand a little bit about what you learned regarding cancers outside the colon?
Yes, so in the 2011 paper, we saw a non-significant impact on the non-colorectal Lynch cancers. And indeed, what we found was there was still an effect, but it wasn't significant. And particularly the endometrial, we only had, I think, 12 endometrials in the placebo group and 5 in the treatment group. So the effect was in the same direction, but it didn't seem to be as sustained. And that's perhaps not surprising. I mean, to actually expect a treatment to keep working 10 years after you took it is quite a lot to expect. So, but the other interesting thing is, although it didn't achieve significance, in our 20-year data between Finland and the UK, you could see that the non-Lynch cancers were also separating. Again, not significantly, but in keeping with the general epidemiology, that basically there is a generic impact on neoplasia of aspirin, which we need to factor into our thoughts about how this is working. And Tony might like to reflect further on that.
So there was a preventive effect in 2011 paper, but it was not sustained as significant result in this paper, as you mentioned, but there is a clear trend, although the trialists, as you said, do not exactly like the word having a trend somewhere.
So along those lines, what's your hypothesis for why there's this sustained benefit? A 25-month treatment period is quite discrete, and yet you're seeing risks continue to split off 10 to 20 years after that treatment period.
So the short answer is we don't know for sure. Clearly, there is an anti-inflammatory story here because the epidemiology of the American Cancer Family Study, for example, shows a very significant reduction in ibuprofen and aspirin regular users. So it does seem to be a generic anti-inflammatory effect. But on top of that, what we have to remember is what aspirin is. It's acetyl salicylic acid. Salicylic acid comes from plants. Willow, Salix alba, makes a lot of it to stop you eating it. But in fact, all green plants make salicylates as a trigger to apoptosis or programmed cell death. And they use it as a defense against infection. And wild plants have quite a lot of it, whereas our modern diet contains none at all because we farm and they don't get infected. It's not a huge leap of the imagination to think that as a natural component of our ancient diet, it was a component of apoptotic stimulus. And if you lose that or diminish your apoptosis, then aberrant cells can accumulate, which over a period of years could become cancers. And conversely, if you can kill them off, you might see the benefits playing out over a decade of the cancers that you were going to get, but you killed them at birth, so to speak.
Yes, and I think we have to think about what we know about the mechanism of action in carcinogenesis of Lynch syndrome, and we think that the efficacy for long-term effect may actually reflect the effect on intestinal epithelial stem cells that have already acquired the malignant potential by losing their ability to repair mismatches. As we know that there are these deficient mismatch crypts everywhere on healthy appearing Lynch syndrome large bowel mucosa and even endometrium that show lack of expression of these gene products. But we don't actually know if the removal of these cells is due to apoptosis or increased immune surveillance, as you mentioned.
Yeah, and that's a very good point, Tony, because the other thing that you do see an upregulation of immune surveillance with aspirin. There's a lot of literature in that area. And that would be another plausible explanation that basically maybe the body is just better able to kill off those aberrant crypts. And as Tony quite rightly says, we have to look at the tumorigenesis in this syndrome. Although you clearly can get an adenoma that goes bad, and we have one or two pictures of that with our collaboration with the Heidelberg group. Ursula Adover and Matthias Kluwer have published a lovely piece of work looking at the different pathways, and probably the most likely pathway is you get an aberrant crypt, which then gives rise to a dysplastic lesion, which then becomes a cancer. So it's really MSI from the start. And of course, that reflects on Tony's world and the work that he's been leading on surveillance in these patients and how best to prevent cancer, because clearly we need to rethink that whole process.
Yeah, so certainly a complicated and evolving story. Some of the themes that you brought up in terms of the mechanism of action regarding inflammation, for a clinician, raise questions about whether there are certain subgroups that may respond to aspirin better than others, whether it be medical comorbidities such as metabolic syndrome, which has been associated with inflammation, obesity, or even genotype. Can you talk about whether you learned anything about those clinical subgroups in this clinical trial?
Yeah, so one of the things we obviously looked at was the genotype in terms of mismatch repair genes, and that didn't seem to show anything. It wasn't a driver. But one of the big differences was the BMI, the body mass. So given the general literature on obesity and inflammation, we looked at the body mass index in our CAP2 patients, and we published a paper 4 years ago with Movedi's first author, where it was quite remarkable that the cancer risk in Lynch patients who were obese was 2 to 3 times higher. But it didn't reach significance in the aspirin group, whereas it did in the placebo group, which does raise the question of whether the aspirin might be diminishing that pro-inflammatory state associated with obesity. But there's no doubt that I think we as clinicians often segregate gene environment. You know, we say, well, either talk to this person about their lifestyle or that person about their genes. But of course, if someone has a genetic predisposition, then they are the ones who really need to think about their environmental triggers. And obesity is clearly a significant factor in this patient group.
It is known that obesity increases the risk about 2 to 4-fold, right? But actually the aspirin abrogates that effect, but it does not decrease the incidence of adenomas, really. So it has to do something with the pathogenesis that we were talking about before.
Yeah, the one thing I would say about the adenoma story, and Tony, which we've discussed many times, is that, I mean, in the CAP2 first paper, we counted adenomas, but this was a hugely diverse endoscopy community across all countries. And so it was a very noisy study. We now know that the lesions in Lynch syndrome are particularly difficult to spot in the ascending colon. And we may well have diminished that number without being able to measure it reliably. And of course, there is a literature that says that aspirin does reduce adenoma formation in the general population, but the likelihood is that that's not the primary story, but it's part of the story.
So for clinical audience, based on these results, can you give us a sense of what you would recommend to Lynch syndrome patients in terms of if to start aspirin, when to start it, what dose, how long to stay on it?
Yes, so we'll take another 30 years to answer all of these questions, and I don't have time, so I'm having to make a few guesses here. So the first thing is to say we started another trial, which you're aware of, CAP3, and we've randomized 1,879 people in the UK, Finland, Israel, Spain, and Australia. It's a lot harder to do international trials now. The regulations have got much tougher. But we've got a whole bunch of people taking different doses of aspirin. The first of them has completed his 5 years, and the last recruits will complete their blind section next spring. Then they'll go on to the same dose on open label for a further 3 years. So we're getting some blind data on side effects and then a long-term study on cancer hard endpoint. And again, we're using centres that have absolutely nailed to the ground cancer notification. So in Britain, it is a requirement that all cancers are placed in the central registry. So we've got access to that data, which will obviously give us reliable information. So we'll tell you in 2024 whether there is a significant cancer difference between 600 milligrams, 300 milligrams, and 100 milligrams. In the meantime, our National Institute for Clinical and Healthcare Excellence, NICE, have now agreed that the CAP2 data is sufficiently strong to recommend aspirin to all Lynch patients. Interestingly, it's not licensed in Britain for this use, and that's a separate request, but it is recommended. We've suggested a dose of 150 to 300 milligrams, 300 milligrams for the people over 70 kilograms, which obviously is an awful lot of our patients, and a smaller dose for those below. It's worth reminding you that Peter Rothwell's data was gone back on all of the old clinical trials for cardiovascular disease. Has now shown that really 75 to 81 milligrams is a little too low a dose for people who are above 70 kilograms. 2 baby aspirins a day is probably a kind of reasonable start point in the people in their 40s to 50s and up to 60. But of course, the other thing we now know is that the side effect profile of aspirin climbs precipitously in the last decades of life. The latest S.3 data, where they started people on aspirin at the age of 70, didn't see a benefit, and if anything, saw a disadvantage, although it's a little bit complicated why that happened. But what we're saying now to people, and I spoke to a patient actually just last night, one of our enthusiastic CAP followers, I've told him to stop his aspirin now. He's 74 years old, he's been on it for several years, and he'll see that benefit roll out for the next decade or more. But the side effect profile is reaching that stage where it's probably safer to stop.
You're essentially telling your older patients that given the prolonged benefit that you're seeing, that perhaps it would be more benefit to them and safer to stop aspirin in their 70s.
I have to second the recommendations in the meanwhile before reaching the CAP3 endpoints, but the European Hereditary Tumor Group guidelines were recently published, and we had to be a little more cautious with recommending only one low-dose aspirin, but increasing the dosage for those with above average body mass, which is over 70 kilograms.
And I think, that's not an unreasonable suggestion also, because it's entirely possible, bearing in mind my comments about maybe losing salicylates from our natural diet, it may well be that the enhancement of apoptosis and immune response is obtained with a smaller dose than these traditional cardiovascular doses we spoke about. So we simply don't know for sure whether a small dose is enough. And certainly we want to avoid side effects because this is a long-term treatment, but also to encourage people to take it sort of steadily in their middle years. It's worth remembering that there was no statistical significance between side effects on the 600 milligrams in the treatment and placebo group in CAP2, because younger people get very few side effects from aspirin. Physicians tend to meet their patients in their 70s and 80s coming in with bleeds and get a very bad impression. And gastroenterologists and surgeons like Tony are sort of trained to not like aspirin because their wards are full of 80-year-olds with holes in their stomach. And I think we need to recognize that. This week are starting a new PhD project because we've got a really interesting mouse model with a mitochondrial knockout If you look at a person of my age, about 10% of my crypts will have dysfunctional mitochondria. And if apoptosis is one of the mechanisms, then that actually is dependent on mitochondrial function. So we have a biological basis for saying old colons are going to get less good at this. So we've got a mouse with a knockdown mitochondrial mutation as well as a polyposis gene, where we can actually study the effect of aspirin on a young and an old colon biologically. Some very nice work under Laura Greaves in our university has demonstrated this model is a nice model for the human situation. So we'll be able to say in the next couple of years whether we can see a biological basis for the difference in aspirin efficacy. We'll report back on that in a couple of years' time. But in the meantime, I think it's reasonable to say for the older community, come off the aspirin once you sort of reach 70 years and 10, get a bit biblical, but try and get onto it as early as possible.
I have to say that much of the bad reputation of aspirin is actually based on the era before Helicobacter bacteria eradication was available. So people do remember these bad things.
Yeah, absolutely. And I think that's the point, Swathi, because I'm sure you have got H. pylori eradication as part of your Lynch management. And again, that will diminish the side effect profile of the aspirin in that population.
Dr. Sippel, I have a question for you. Taking a step back, how do you place these results in the context of our armamentarium of Lynch syndrome prevention that we offer patients? And at the risk of perhaps opening a whole new podcast topic, how do you place these results in context with what you're learning from the prospective Lynch syndrome database?
Yeah, I have to say that the large prospective data, such as PLSD, have informed us that the endoscopic prevention of colorectal cancer is not very successful in Lynch syndrome, possibly due to reasons related to cancer biology that we talked about before, which is actually the same reason why aspirin reduces the risk of colorectal cancer without substantially reducing the risk of adenomas. It looks like the effect size of Lynch syndrome colorectal cancer prevention by colonoscopy at long term is much, much smaller than it is for aspirin, which has number needed to treat of 24. So the regular 3-yearly endoscopy clearly has its role, however, in identifying the colorectal cancer early enough to reduce mortality. But the actual means to prevent colorectal cancer are accurate identification of pathogenic variant carriers and treating them with aspirin and performing extended surgery for their first colorectal cancer.
Yeah, I think that's an important point, Tony. And in fact, one of the things that we've just developed, and I have to declare an interest, we have a patent on a new next generation sequence MSI test, which is very cheap and fast. So we can do MSI testing on all cancers. And in fact, we're gearing up to do it on all biopsies as well. And that would allow us to know that a patient has Lynch syndrome before they reach the surgeon. Our original case patient who gave us the DNA for Kolodner's project died of his 3rd colon cancer. So we really need to get these patients in with a different conversation about surgery. But also to reinforce that point on endoscopy, I actually said to the American Association of Gastroenterologists and survived the lecture when I pointed out that they were more likely to kill patients with their colonoscopes than I was with my aspirin. And actually, that's what the statistics tell us, that basically if you're doing annual colonoscopies to people from the age of 25, that's a lot of scopes. And although it's rare, it does go wrong sometimes, even in a diagnostic setting, and especially if you're doing, biopsies of the ascending colon. So I think we need to try and reduce the frequency of scopes. And certainly in Europe, we're very determined not to support annual scopes. And indeed, the Finns have obviously demonstrated efficacy with 3-yearly scopes. And we're probably discovering lesions that were about to disappear of their own accord. That's our hypothesis anyway, that from Tony's work. But the other thing is that these tumors are highly immunogenic and are very bad at metastasizing. So they tend to stick around for a long time. You have time to actually remove them. And I think our move to annual colonoscopy in Hans Varsen's day was because we couldn't understand the ever more frequent scopes, they still had cancer. And because we were convinced it had to be polyp removal. Now we know about aberrant crypts, that basically these things just pop up like mushrooms from an aberrant crypt. You didn't need an adenoma sitting there beforehand. So the whole premise of the polyp removal approach actually is open to question. Now, of course, the endoscopists, I'm sure, are listening in the States and saying, yeah, well, you guys don't do them properly. But I can assure you, only screening colonoscopists are allowed to do them. So these are top-notch people with top-notch equipment. This is really a biologically different space.
Certainly an evolving discussion and a complex one. Thank you so much for distilling it down for us today. Before we close, I wanted to see if you have any additional final thoughts to impart on our audience. Professor Byrne?
So first of all, I think we need to sort of do co-development with our patients, explain to them the risks and benefits of aspirin and give them the opportunity to take aspirin. It's worth reminding them that we did a paper 6 years ago where we analysed the epidemiological benefit. The benefit in terms of cancer prevention in the population at large of aspirin is 6 to 8 times greater than the benefits in terms of cardiovascular prevention. So it's almost a pity the cardiologist got there first. It's a much bigger story in oncology. And my final thought is that in COVID-19 land, we're using FIT testing on our patients to help target our scopes because we're under pressure. And that's, I think, something that could be further developed, that using FIT testing between scopes. We've introduced a national program in Britain of FIT testing our Lynch patients when they are coming up for their scopes to try and triage the ones who need scopes first. And it seems to me that you often get these lesions sitting around for a while, that a FIT test in between scopes might be a logical way forward. And then, sort of do it too yearly at least, but maybe do an intervening yearly FIT test just to reassure yourself that there's unlikely to be pathology there.
Thank you. And Dr. Seppala, any final thoughts for our audience from your perspective?
I would like, for the future directions, I would raise a possibility of precision medicine in selecting those that we monitor more intensely. For example, circulating cell-free DNA or other biomarkers. I'm confident that they will be of assistance at some point to select those individuals that we need to look closer.
And that's a story for another podcast too.
That's right. We will be inviting you back. Well, Professor Byrne, Dr. Seppala, thank you so much for this hot off the press update on aspirin chemoprevention in Lynch Syndrome. To our audience, please be sure to review the paper entitled Cancer Prevention with Aspirin in Hereditary Colorectal Cancer Syndrome, or Lynch Syndrome, 10-year follow-up and registry-based 20-year data in the CAP2 study, a double-blind, randomized, placebo-controlled trial. This paper was published in the June 13th edition of 2020 of the journal Lancet. A link to the citation can be found in our podcast descriptor. Stay tuned for our next CGA-IGC podcast where, as always, we will be reviewing the latest and greatest in hereditary gastrointestinal cancers. Thank you for your attention.